Okay, well, I'll go ahead and get started while they're working on troubleshooting the mouse function here. I think I can still advance most of the slides. So my name is Jennifer Dundee. I'm one of the reproductive endocrinologists and infertility specialists at UVM. And today I'm going to be talking about addressing fertility for women with a recent cancer diagnosis. Just to put this in context, over 100,000 people less than age 45 years old are diagnosed with cancer every year in the US. So over the past 4 decades, advances in cancer therapies have resulted in dramatic improvements in survival. So back in 2006, the American Society of Clinical Oncology first published recommendations on fertility preservation, stating that as part of education and informed consent before cancer therapy, oncologists should address the possibility of infertility with patients treated during their reproductive years and be prepared to discuss fertility-related options or refer patients to a provider that's comfortable discussing those issues. So even though that recommendation has been made over a decade ago, fertility preservation services have been largely underutilized thus far. And studies have shown that even if a patient chooses not to utilize services for maintaining fertility after cancer treatment, just having had the opportunity to meet with a specialist and discuss what those options are in advance gives a much greater sense of control over what's happening and feeling at peace after the treatment is completed. At least the patient was given the opportunity to make an informed decision about whether or not to pursue those treatment options. So the two main objectives of my talk today: to increase awareness of how cancer treatment can impact future fertility, and also to review options for fertility preservation before receiving treatment for cancer. So to review the reproductive outcomes following cancer and its treatment, factors that contribute to this include but are not limited to the fact that it can be really difficult to predict exactly how reproductive potential will be affected by cancer or a cancer treatment. Many variables contribute to the reproductive risk, including age at the time of diagnosis likely being the most important factor, genetic background, which we'll talk about more towards the end, medical history, and fertility potential prior to the cancer diagnosis. Because we know that some women are more at risk of premature ovarian insufficiency related to underlying genetic mutations, which can also put them at risk for specific cancers, such as BRCA-related cancers. We also know that the radiation and chemotherapy regimen significantly impacts future reproductive function. So not just the dose, but the duration, the frequency of treatments, the field of the treatment, and whether or not chemotherapy is combined with radiation therapy. Do I have to go one? Okay. It's hit or miss here. So here we see that we know that several. Are you here to help with that? Yeah, the mouse is not working. It's not letting me.
Not at all. I thought maybe you had a wireless or something.
Mm-mm.
So can you use the arrows to advance and go
Most
back
of the
and
time
forth?
they're working.
These?
Yeah, they haven't always been working.
Let's try it.
Okay. So in order to have an intact reproductive system, a woman must have a functioning neuroendocrine system, because this is the primary site that regulates the menstrual cycle and helps to maintain a pregnancy. Also, we need a healthy pool of ovarian follicles that grow in response to hormonal cues and produce mature and fertilizable gametes. A woman also needs a receptive uterus that can support embryo implantation and fetal development to term. And cancer treatments can affect each of these systems separately. So although today we're focusing on the effects of female fertility, it's also important to remember that the male gonads and endocrine system are also highly sensitive to common cancer therapies. And luckily, it's pretty straightforward for a man to have options to preserve fertility in the future. it's much quicker and easier to store sperm than to go through the whole process to store eggs. So we're focusing on just how this affects females.
Oh, I see the mouse.
Yeah, it's only, I have to go up there to do it. Okay. So first, we're going to go through how cancer therapies can affect the neuroendocrine axis. So this is also referred to as the hypothalamic pituitary gonadal axis. This controls the menstrual cycle and pregnancy by regulating secretion of hormones, including gonadotropin-releasing hormone, follicle-stimulating hormone, luteinizing hormone, estradiol, progesterone, and prolactin. So the HPG axis is vulnerable to off-target effects of cancer therapies, and we know that this regulatory center is absolutely required for control of the menstrual cycle because of the secretion of these hormones. And radiation therapy is the biggest culprit for having an effect in this area, especially cranial radiation, which can alter hypothalamic and pituitary function. But we also know that hypothalamic dysfunction can occur just after chemotherapy, even in the absence of cranial radiation. Cancer also has a significant impact on ovarian function. Actively dividing cells are much more susceptible to radiation-induced death, and luckily oocytes in their early stages are arrested in prophase of meiosis 1, if you think back to your high school biology and the cycles through meiosis. So they're more relatively resistant to radiation, and primordial follicles as well are quiescent. Nevertheless, the human oocyte is very sensitive to radiation therapy. And the LD50, which is the radiation dose required to destroy 50% of immature human oocytes, is less than 2 grays. People have used mathematical modeling to predict that the effective sterilizing dose of radiation is actually inversely correlated with age. So it takes a higher dose of radiation to effectively sterilize a young woman or a girl than it does later in life, because ovarian function has already started to decline, so the ovaries become ever more sensitive to the negative impact of radiation. So in order to be able to more accurately counsel patients about their ovarian function, we have a number of tests that we can check both before she undergoes chemotherapy or radiation and also afterwards to see how it may have affected her. The one that we're using the most currently is called AMH, which is anti-Müllerian hormone. The benefit of this particular blood test is it can be checked on any day of the menstrual cycle. And this hormone is made by the granulosa cells of growing follicles in the ovary, so it's really kind of a surrogate marker for the size of that pool of growing follicles. It's best performed in combination with a transvaginal ultrasound for an antral follicle count, because those two tests have a synergistic prognostic benefit for ovarian function. The more classic tests that we have done are done on day 3 of the menstrual cycle, so checking a follicle-stimulating hormone level and an estradiol level. Estradiol is made also by the granulosa cells in the ovary, primarily, also a little bit made by the adrenal cortex, and FSH being made by the anterior pituitary. So a high FSH correlates to low egg count in the ovary, and it's important to remember that an abnormally elevated estradiol on day 3 of the menstrual cycle can suppress FSH, so it can give you a falsely reassuring FSH level. So we see this happening in women who are undergoing premature ovarian insufficiency because they start recruiting a whole pack of follicles during their luteal phase of the prior menstrual cycle. So they've already got growing follicles very early in their next cycle when we're checking this on day 3. So they have larger follicles that are already secreting a fair amount of estradiol, which falsely suppresses the FSH. So it's very important to get those two tests together so you can accurately interpret the FSH. Then we also have transvaginal ultrasound available to us. And for those of you who may not know, we have our own GYN ultrasound unit at the hospital. So our sonographers are completely dedicated to doing GYN scans. And we have a system where the physicians can go in and talk to the patients after the scan and discuss the results on the same day, so they don't have to wait, in contrast to if they were sent to radiology for a scan. And we found a good amount of patient satisfaction with that system. So the test that we can do as an investigation of fertility potential is called the antral follicle count. This is ideally done early in the follicular phase. So we count up all the small growing follicles between 2 and 10 millimeters. And again, this is a reflection of that growing pool that's available. It's just that the group that gets recruited every month by the ovary, and then in a normal menstrual cycle, the one follicle becomes dominant. That's what gets ovulated, and the rest of them die off by atresia. But the size of that pool that gets recruited is indicative of the fertility potential of that woman. So, for example, when we do this ultrasound in women in their early 20s, we can see 30 or 40 antral follicles in that pool. But by the time a woman is 42, we typically see more like 5 to 10. Seeing over 10 for a woman in her early 40s is pretty unusual, unless she has polycystic ovarian syndrome. Some studies have looked at whether ovarian volume has any real prognostic value for fertility potential, and the clinical value of this is pretty controversial. It's well agreed that the antral follicle count is the better test to do. But, we can still look at the ovaries, and certainly if you see an ovary that's twice the size of another one, that implies that the smaller ovary has a lot less of that follicle pool left to be recruited, fewer primordial follicles available, and is likely much more close to when the menopausal transition will occur. But it's not as precise. So we've talked about the effects on the brain and the ovaries. Can't forget the uterus. You cannot carry a pregnancy to term if the blood flow to the uterus has been severely impaired. We know that chemotherapy alone seems to not have adverse effects on the uterus, luckily, but radiotherapy is what can really cause the most negative long-term consequences. After women who have received direct pelvic radiation are noted to have reduced uterine volume subsequently and reduced elasticity of the tissue. So it damages the uterine musculature and the endometrium, as well as the vasculature supplying the uterus. Because of this, we note an increased risk of adverse pregnancy outcomes after women who have had pelvic radiotherapy, such as higher rates of miscarriage, placental abnormalities, preterm birth, and delivery of infants with low birth weight. We know that the uterus functions primarily to support embryo implantation as well as fetal growth and development. So women who are able to conceive following radiotherapy may benefit from more close surveillance during pregnancy to monitor for adverse events. Unfortunately, we have pretty limited ability with our current diagnostic techniques to quantify the negative impact that the uterus has sustained from having direct radiotherapy. The last area I just want to mention, because this is worth a discussion, maybe mentioning in advance, but certainly needs attention afterwards, and patients don't necessarily always bring this to their provider's attention. But there is a high rate of sexual dysfunction in women after chemo and radiation, especially after pelvic radiation, or women who have had an oophorectomy, either one or both of their ovaries removed, which would cause them to become surgically menopausal. And especially in young women who undergo that treatment, it's very important to have a plan in place for hormone replacement, assuming they didn't have a hormone-responsive cancer that would put them at higher risk from such treatments. But just to maintain bone health and minimize the risk of cardiovascular disease later in life, but also for quality of life issues such as being able to enjoy intercourse and not have significant dyspareunia from vaginal dryness. Or we also do see a significant amount of vaginal strictures after radiation therapy, which is directed in the pelvis. Women who take aromatase inhibitors as part of their maintenance therapy after cancer diagnosis can have a high rate of vaginal pain associated with just the decreased estrogen in the vagina. And there are a number of treatments available to address this, so absolutely worth asking patients about this just to make sure they're not suffering from this. So the next few slides are about infertility risk associated with specific cancer treatments and regimens. And all this data can be found online at this website, and I put a couple of the reviews that are really helpful about this. I'm not going to focus too much because these slides are very specific, but just so that you know that this information is available and updated constantly, since the cancer treatments are constantly evolving as well. So the ones that are known to be at highest risk of causing infertility after treatment are listed here. So we know that, in addition to being radiosensitive, the ovary is also very chemosensitive, and alkylating agents are probably the biggest offender here, especially cyclophosphamide and busulfan. They are the most gonadotoxic compared to other chemotherapeutic agents, like the platinum-based drugs, plant alkaloids, and antimetabolites. So alkylating agents cause DNA breaks regardless of point in the cell cycle stage, so that's why they are so toxic. Let's see. And we also know that follicle destruction, whether it's caused by radiation or chemotherapy, not only leads to gamete loss, but keep in mind that it impairs ovarian hormone production and uterine dysfunction. So although many follicles may resist cancer therapies initially, it doesn't mean that a woman's going to be immediately menopausal afterwards, but she may very well be at increased risk of undergoing early menopause. So there needs to be a discussion about not delaying time to conceive if that's a high priority for her, because the ovarian reserve may be significantly depleted as a result of the treatments. So these treatments listed here are known to have intermediate or low risk, and you can see, what I was talking about earlier, that in postpubertal girls, the dose is that's related to intermediate risk is 5 to less than 10 grays, but then doses greater than 25 grays in women to 30 to 39 years. If it's specifically spinal radiation, causes the greatest impact. And then luckily we have a couple treatments that have no risk whatsoever associated with them, such as radioactive iodine treatment, surprisingly, methotrexate and vincristine. And then more of the newer treatments, all the monoclonal antibodies, we really don't know yet. So stay tuned in the future for more information about this. So just to summarize, when counseling a patient about her specific risks after she's diagnosed with cancer, we've got to consider how the components of her treatment may impact both her neuroendocrine function as well as the uterus and ovaries. So certain therapies pose little to no risk for future reproductive function. So for some patients, all that's needed is just to make an assessment of that, and then she can feel reassured that she doesn't have to worry about this piece, and she can just focus on getting her treatment and getting well. But if we do identify that she's at significant risk of fertility impairment after treatment, then we can move on to the next part of the discussion, which is what are her options for fertility preservation once the cancer diagnosis has been made and the treatment plan has been set in place. Any questions about that first part before I move on? Okay. So these are the areas I'm going to cover in this part of the talk. Fertility preservation in women with cancer can be performed by using medical protection of the gonads. The most common and the most assured method for doing this is by either freezing embryos historically, but now also by freezing eggs. Just within the last 5 years, egg freezing has gone from being experimental to being mainstream, and now we're seeing donor egg banks crop up all over the country for use in IVF cycles for women without a cancer diagnosis who have, or women that have had a cancer diagnosis if they don't have good enough ovarian function. This is an option that has really increased the possibilities for women, because especially in a smaller state like Vermont, we don't have a huge population of young women who are eager to be egg donors. And some patients are worried about the fact that we have a smaller population, and what if my child has a sibling in the same school with them, or what about them, the possibility of my child having, marrying and having children with somebody who is closely related to them in the future. So that those concerns do come up. Like in Great Britain, for example, they have really tight limits on how many times a woman can donate eggs even. But so it's nice to have the option of a donor egg bank where patients are being pulled from all over the country and patients can look through the characteristics of the egg donors and select somebody that has similar characteristics to themselves, so that they feel that those physical attributes will be possibly be more likely to be reflected in the child. Another method which is available but is more, the American Society for Reproductive Medicine still considers it more in the experimental realm, but it is being routinely done, especially at centers that have a very high focus on fertility preservation, like Northwestern and Chicago. They do ovarian cortex freezing for subsequent transplantation back to the ovaries subsequently in life, and we'll talk about that a little bit more in detail shortly. And then just at the end of the talk, I want to spend a few minutes talking about special considerations for women with a breast cancer diagnosis, because there are some extra things that need to be addressed during their counseling visits. So first of all, to go over medical protection of the ovaries, I just want you all to know that the FDA has not approved the use of gonadotropin-releasing hormone agonists for fertility preservation. There have been hundreds and hundreds of studies published on this topic. So we know that GnRH analogs can be used for ovarian protection while a woman is receiving chemotherapy, but it is a highly controversial topic among REIs across the country. The thought is that if you give somebody Lupron, it will put their ovaries into a temporary menopausal state and keep those follicles from being recruited into the growing phase, so they're more in a quiescent phase, and they're likely to be safer from the negative effects of chemotherapy at that point. Also, so the studies that have been done mainly show that menses, and menses particularly, is more likely to recur if a GnRH agonist like Lupron is used during chemotherapy. Fewer of the studies have actually looked at ovulation, and the ways to assess for that is to check a luteal phase progesterone level to see if it's elevated, but that gives you a surrogate marker for ovulation likely to have occurred, but truly the only proof of ovulation successfully having occurred is a pregnancy occurring afterwards. So the studies that have specifically looked at pregnancy are very few and far between and have some conflicting results. So we really have inadequate data on benefit for fertility outcomes. So we know, yes, menses is more likely to resume, but menses doesn't guarantee that ovulation is occurring or that fertility is even possible. So I think it can be kind of a falsely reassuring thing for some women, and it's really important to make them aware of that. The most beneficial impact of using Lupron during chemotherapy is to prevent heavy bleeding for women who take chemotherapies that can have a side effect of thrombocytopenia and predispose to very prolonged and very heavy bleeding. And in women who have cancer and are undergoing treatment, our options for stopping that bleeding are much more limited because in general, cancer patients are so much more at risk of thrombotic events, and so we don't want to use high-dose IV estrogen to stop her bleeding. We just have a lot fewer things we can do in this situation. So that can be one argument for using Lupron if somebody's at risk of that, or for women that have leukemia who are at risk of menorrhagia because of their primary diagnosis as well. So when I talk to patients about this, I tell them it may or may not preserve your fertility, but if you want to not have to deal with menses during your treatment, it's not a bad idea, and it may have this added benefit, but we can't guarantee that. Thank you. So Lupron can have some significant side effects because it's such an abrupt transition to the menopausal state. So it can cause significant hot flashes, headaches, mood lability is a big one, and insomnia. So for somebody who may be having significant side effects from their other treatments, yeah. And for women, when we use Lupron to control pelvic pain for endometriosis, we give add-back therapy with norethindrone, which is a progestin, but it is metabolized to estrogen within the body. So, it's debatable whether that's advisable in the context of cancer with a thrombotic risk. Yeah. So just the most widely cited study that has looked at this question was published in the New England Journal of Medicine last year. This was a randomized controlled trial of premenopausal women aged 18 to 49. It was done at the Cleveland Clinic. So women were eligible for enrollment if they had operable stage 1 to 3A estrogen receptor negative and progesterone receptor negative breast cancer, for which treatment with adjuvant or neoadjuvant cyclophosphamide-containing chemotherapy was planned. The primary study endpoint was the rate of ovarian failure at 2 years, with ovarian failure defined as absence of menses in the preceding 6 months and levels of follicle-stimulating hormone in the postmenopausal range, so just significantly elevated. And this study found that ovarian failure rate was 8% in the group that received the intervention in goserelin, and 22% in the chemotherapy alone group. So among the 218 patients that were evaluated as part of this study, 16% had at least one pregnancy, 11% in the chemotherapy alone group, and 21% in the group that received the GnRH agonist. So that was a significant benefit with an odds ratio of 2.45. Of note, the women who became pregnant were younger than those who did not, and we're going to talk more about this shortly, how important their age at diagnosis is for what their options are. The median age of the women who became pregnant was just about 33 years versus 40 years for those who did not. But they were similar with respect to what chemotherapy was planned as part of their treatment. So on to discussing the option of oocyte and sperm cryopreservation. Really the most immediately relevant risk of ovarian stimulation is something called ovarian hyperstimulation syndrome that I want to talk about shortly. So just to keep in mind that these treatments are not without risk themselves. But we absolutely can freeze both eggs and sperm for future use, and if a woman has a partner that she wants to produce embryos with, that she knows she would like to have a child with in the future, embryos can be created and stored. More and more we are counseling women to, if they have somebody they want to use as their sperm donor, whether or not they're in a long-term committed relationship or whatever the case may be, at least I feel pretty strongly about having women freeze some just eggs and then some as embryos, because you never know what's going to happen even without a cancer diagnosis, and going through chemotherapy can be very stressful on a couple, and it's just better to have all your options open down the line now, especially since egg freezing has really become so mainstream. I think it's pretty important to consider that option even for somebody, a couple that have been together for a long time. All right, so I wanted to give you a little idea of kind of the timeline involved on my end for doing ovarian stimulation prior to, not really IVF in this case because we won't be doing an embryo transfer, but before egg freezing or embryo freezing. Typically, in a cancer setting, we're not doing the more standard protocol where we start somebody on Lupron for a couple of weeks and then we add in the injectable gonadotropins. Time is of the essence here, and if somebody is considering delaying their initiation of chemotherapy to do this, we want to use the shortest protocol possible. So unfortunately, the best egg yield is obtained if we wait for menses to occur, so that we're giving these injectable gonadotropins when those follicles are starting to be recruited, because again, think back to that normal menstrual cycle where that whole cohort of follicles gets recruited and then the one becomes dominant and the rest die off. The whole point of giving injectable FSH and LH is to let that whole cohort develop together. So we give supraphysiologic doses of those hormones to support growth of all those follicles and eggs. And then so this involves daily injections of synthetic FSH and LH. And about 5 days in, we'll start monitoring an estradiol level to make sure that it's rising appropriately. And then at that point, every other day the patient is coming in, sometimes every day, for blood tests and ultrasounds to make sure that that her ovaries are responding appropriately, but not over-responding, that ovarian hyperstimulation that I mentioned. And then once we see the majority of the follicles have reached a mature size where the egg inside should be mature and fertilizable, the patient can take an injection of HCG or Lupron, actually, if we're using the antagonist to prevent ovulation, Lupron has this flare effect on the gonadotropins produced by the pituitary, so it can trigger the final maturation of the eggs before harvest. And then 36 to 38 hours later, we perform the egg retrieval. We have a procedure room that is solely for that purpose, contained within our GYN outpatient clinic. And we have the on-call group of anesthesiologists come up to do conscious sedation for this procedure. The egg retrieval itself takes roughly half an hour, but it does involve transvaginal guided retrieval. There's a needle that sits on top of the ultrasound probe, and we suction out each follicle in turn and pool all that follicular fluid, hand it directly to our person in the lab. They look under the microscope, find all of the eggs. And for egg freezing, they keep them in culture for a couple of hours. And every egg comes out with this, it's like almost like the rays of the sun around them. It's called the corona cells because of that, that we have to strip off to see if the egg is mature and then freeze the egg at that point. Once an egg has been frozen, it can be stored indefinitely. It's just as good if you thaw it a week later or 10 years later. And the same goes for embryos. They don't deteriorate over time. So it's truly a suspended animation. And we flash freeze them in liquid nitrogen. It's called vitrification. Once an egg has been thawed, the outer membrane that surrounds it, it's called the zona pellucida, becomes hardened, and it can't be fertilized by standard in vitro fertilization anymore. The sperm can't penetrate through that hardened zona, so we have to use ICSI, which is intracytoplasmic sperm injection. Our lab personnel can inject a single sperm into each egg to fertilize it. So even if a male partner had severely low sperm counts, we can still achieve completely reasonable embryo development with this technique. And subsequent to all of this, if a woman comes back 5 years later, once she's completed her treatment, she's healthy and wants to start her family at that time, to use these eggs or embryos, she doesn't have to go through this entire treatment again. But we do use Lupron again to suppress ovulation so that we can really maximize her uterine response. We give her an stair-step protocol, increasing doses of estrase, of estrogen, to help build her endometrium, and Lupron as well, so she won't spontaneously ovulate during this cycle. Once we see the endometrium is adequately thickened, then we can do the embryo transfer. And this requires intramuscular progesterone shots continued through the 9th completed week of gestation, as well as estrogen supplementation to maintain the early pregnancy until the placenta is making enough of those hormones to sustain the pregnancy on its own. So it's a commitment. It's not an easy treatment, and I want patients to be fully informed about how much is involved in going through this process, but it is absolutely doable. And I do also spend a little time talking with them about the risks of this. So just to get back to that, so it takes about 2 weeks from start to finish, just like in a normal menstrual cycle, for the time that it would take to get to ovulation. We can get all of those eggs to a point to be mature and ready for harvest at that point. And then afterwards, she could be immediately ready to start chemotherapy. But just the risks that I talk to all my patients about include the one I alluded to, ovarian hyperstimulation syndrome. So if you think about in a normal menstrual cycle, that one dominant follicle makes estradiol at a level of about 400. But if you're growing 15 mature eggs, every one of those follicles is making estradiol, and levels can get to be 4,000. They can get to be over 6,000, actually, especially if it's a younger woman going through this process. And at that level, it can be actually considerably dangerous for her. So that's part of why we have patients coming in every couple of days for monitoring, because if we're seeing that the estradiol level is on an exponential rise, we'll have her drop way back on the medication she's taking to avoid getting into that danger zone. Because in its most severe form, this happens very rarely these days because we're so obsessive about the monitoring. But women, with that high of an estradiol level, the serum leaks out of the vasculature, and what's left behind, those red cells become much more hypercoagulable. They're much higher risk of PE. And then the serum that leaks out can accumulate in the lungs or in the abdomen as ascites and can cause quite a bit of discomfort. This syndrome is most severe when a pregnancy immediately follows the ovarian stimulation. So In general, women going through this for fertility preservation are at a lower risk because it's the HCG of the early pregnancy that can perpetuate these symptoms and magnify them. So there's an even lower risk if we're doing an antagonist protocol, like I just showed you in the prior slide, where we wouldn't start the GnRH antagonist until we see a 14 millimeter follicle, and that's just to prevent the eggs from being spontaneously ovulated. But in that case, we can use a Lupron trigger instead of HCG trigger. So again, you don't have that HCG contributing to these symptoms. Birth defects from babies conceived by assisted reproductive techniques only really very minimally increased over the general population risk, which is 2%. So in some studies, we've seen up to 2.5% risk of birth defects in all comers of IVF, including frozen embryo transfers. But there is not one specific kind of birth defect that's found more commonly, which I think is a reassuring finding. And this may be mostly related to the fact that the data for IVF pregnancies is coming from a skewed sample of the population where a lot more of our patients are in their later reproductive years. So it may just be more due to underlying genetic causes. And the other risks I discussed with them, risk of ectopic pregnancy, multi-fetal gestation, we can control pretty well by just doing a single embryo transfer, and I'm a strong advocate for that with my patients, especially after cancer treatment. I think doing single embryo transfer is kind of the most prudent course of action. But even with that, because these embryos have been manipulated in culture, there's a less than 1% chance that the embryo can split into an identical twin gestation. And we do see that more commonly in pregnancies from assisted reproduction than in the general population. The procedure-related risks of egg retrieval are pretty minimal. You know, like I was describing, it involves the needle going through the vaginal wall. The ovaries are literally sitting right on the other side of the vaginal wall inside the pelvis, because when they get stimulated, they get much bigger than normal and they drop down low in the pelvis, so they're easily accessible from a transvaginal approach. But there can be bleeding from the site where the needle goes through the vagina. There can be bleeding from each puncture site into the ovary. And less than 1% risk of infection. We use a prophylactic dose of ANSEF at the time of retrieval. Rarely in women who have had multiple prior pelvic or abdominal surgeries or have some unusual anatomy, there's a risk that the needle could go through the bowel, or in obese women where it's harder to see with the ultrasound, there's a higher risk of that as well, but that's exceedingly uncommon. Just to give you an idea of success rates with these technologies. And this is the way that the society that we report our success rates to has reported the data has changed significantly recently, but I like this graph the best. I think it's the clearest for just to give you an idea. And honestly, over the past 6 years, the success rates have not changed very much, more than about a percentage point, really. So you can see here that data from fresh and thawed cycles, you can just see how dependent it is on the woman's age for a fresh IVF cycle. And for cancer patients, everything we'll be talking about will be using thawed material. But the general pregnancy rate, all comers, for using frozen thawed embryos is about 40%. But really, you know, for women with a cancer diagnosis who are in their early 40s, even with our best technology, we're really limited by the genetic makeup of the eggs. That's the biggest factor that we cannot change, because, you know, we're born with all the eggs we're ever going to have, and we carry them around with us, and they're exposed to environmental toxins. And women who smoke have a higher risk of aneuploidies and miscarriage related to that. Women who smoke actually go through menopause a year or two earlier with a heavy smoking history. So we can't change that damage that's already occurred. And in these cases, the only thing we can offer to significantly improve those rates is use of donated eggs from a younger woman. But, you know, as of a recent survey, you know, over 5 million babies have been born from IVF cycles since it was first implemented in 1978. So we have a lot of data about these pregnancies, and you know, we don't have as much in the setting of a cancer diagnosis and cancer treatments and pregnancy rates after that, especially since egg freezing in particular is a relatively newer treatment option. So we're extrapolating most of our data for the counseling from just standard IVF cycles. but it's likely that a woman who didn't have some underlying infertility diagnosis, she may have a much higher fertility potential in general before undergoing her cancer treatment anyway. So any lingering effects from her treatment may kind of balance out with that, having not had an infertility diagnosis to begin with. So the last bit, I want to talk just about the IVF process, just to show you here again to emphasize that fact that the live birth rate using fresh non-donor eggs, so this really reflects the age of the woman going through. You can see how steeply that curve starts really for women in their late 30s, early 40s. And the inverse of that is the miscarriage rate. And again, this is all related to the underlying egg quality. So we know that the miscarriage rate is over 50% for a woman by the time she's about 44. So, and I'm very upfront during these counseling sessions. I don't want to give people a false sense of security. I want them to really understand the limitations of our current technology and that this is available, but there is nothing we can do to guarantee a pregnancy after any of this. And it's also important for patients to know, this is just a general comment that it's important to review the contract for storage, because a lot of fertility clinics will ship out stored tissue to other locations that have a large storage capacity, and then there can be significant expenses with getting it shipped back once you're ready to use it. And luckily, we keep everything on the premises here, at the hospital. And it's also important just to know the skill set of the center that you're going through these treatments with. Again, like I mentioned, using thawed eggs requires a lab that has expertise with doing that ICSI technique. Using thawed embryos is certainly technically less difficult, but again, requires that you have somebody you want to reproduce with. So now just to talk a little bit about some of these more experimental techniques. So we've talked about some of these pathways here, but I really want to focus on transvaginal retrieval of immature eggs. There are a lot of labs working on improving culture techniques for immature eggs. It's called in vitro maturation. And so this is something that we would like to be able to offer patients who have estrogen-sensitive tumors, who we don't want to put them through this whole ovarian stimulation and put them through the added risk of having an estradiol level of 6,000 when they have an estrogen-sensitive cancer. So then, in this case, we would retrieve immature eggs in unstimulated ovaries and then mature them in culture. This requires that a patient have gone through puberty. We cannot do this before puberty. There have actually been several live births reported using this technique, but it is definitely still considered experimental. We don't have data on long-term efficacy or safety. And then the next kind of experimental technique involves ovarian tissue removal. This can be done either by biopsying little core pieces of the tissue or removing an entire ovary and then cryopreserving that tissue. This is currently the only option available for prepubertal girls and certain patients with hormone-responsive cancers, or if the cancer is so aggressive that you can't delay treatment to go through even a 2-week time period for egg retrieval. And then we know that this ovarian tissue has both dormant primordial follicles and growing follicles, and that these dormant follicles can reestablish endocrine function and fertility if the ovarian tissue is transplanted back to the patient later. And in theory, once we get better techniques of in vitro maturation, even the smallest follicles can be potentially used to obtain mature eggs in the future. So the tissue in this picture was obtained from a 15-year-old girl who had already received immunosuppressive therapy. And so you can see she has visible dormant follicles on the left here and a growing follicle on the right. So importantly, no live births have been reported in females who cryopreserved tissue before puberty. And that it's been observed that ovarian function generally resumes between 60 to 240 days post-transplant, and it lasts for up to 7 years. So this doesn't guarantee normal ovarian function all the way to the natural age of menopause around age 50. So it's unlikely that ovarian tissue transplantation is an effective treatment for preservation of long-term endocrine function. It should only be performed when a woman is ready to reproduce. There's a relatively low follicular survival rate following ovarian transplantation, so it doesn't really appear to be feasible to cryopreserve ovarian tissue from women older than 40 years of age because of that attrition and fertility that naturally happens. So you can see here some human ovarian tissue that's been surgically removed for cryopreservation. There's a legitimate concern with this technique regarding the potential for reseeding tumor cells following ovarian tissue cryopreservation and transplantation in cancer patients. So although many types of cancer virtually never metastasize to the ovaries, leukemias are systemic in nature, and so we think they pose the most significant risk. So because of that, autologous transplantation is contraindicated in situations where cancer cells might be present in the cryopreserved ovarian tissue. That's one of the most significant things to consider. So this is from a paper that looked at all the pregnancies reported after transplantation of ovarian tissue. So you can see the various diagnoses associated with this on the left. It's worth noting that some of these patients were able to conceive spontaneously after, but some of them still needed to go through IVF in order to conceive because the amount of ovarian activity is still pretty low. And even women who initiated chemotherapy prior to tissue cryopreservation were still able to conceive both with and without IVF. So that's a technique that is likely to become a lot more utilized over the next decade, I would imagine. One last thing to consider for women who are going to have direct pelvic radiation, we can do ovarian transposition. This can be done at the time of initial oncologic surgery, but it may preclude subsequent transvaginal egg retrieval if IVF is required later. We can do transabdominal retrievals. They are definitely trickier, and we're more likely to not be able to get all of the eggs that are available, but it is an option. And when time does not allow, when the cancer is too aggressive, some patients will go through their chemotherapy and then go through fertility procedures later. So we don't have human studies looking at the quality of eggs and embryos immediately following chemotherapy. We know these chemotherapeutic agents can cause DNA abnormalities and oxidative damage in both somatic and germ cells. Mice experiments have shown that conceptions within 3 months of exposure to cyclophosphamide leads to a higher rate of miscarriage. So we really don't know what the safe interval of time is for once chemotherapy has been completed. So ideally, we like to cryopreserve tissue before chemotherapy has begun, but we know it's not always a possibility. We do know that live birth rates from pregnancies in cancer survivors are similar to those of siblings who didn't go through cancer treatments. So that's at least a reassuring fact. And it's always worth counseling patients on considering other options. You can use donor eggs, donor sperm. For women who have to have their uterus removed as part of their treatment, they can use a gestational carrier, or if they have significant negative effects on the uterus from radiation, they can use a gestational carrier later, or adoption. Donor eggs are very expensive. It costs about $15,000 to purchase 6 eggs from an egg bank. And gestational carriers can cost up to $100,000. So ideally, if a woman has a family member who's willing to do that for her, that's where we see most of these scenarios playing out, because otherwise it's just really cost prohibitive. So just a couple things about breast cancer. It is the most common malignancy in women of reproductive age. 6.4% of women are younger than 40 by the time they're diagnosed. For BRCA, you can do ovarian stimulation and egg retrieval after they have their mastectomy, before they start their chemotherapy. There's usually about a 4 to 6 week time interval that we can work with for that. But again, we have concerns about those high estrogen levels that I talked about earlier. So we have alternative protocols where we use a lower dose of the gonadotropins in combination with letrozole, which is an aromatase inhibitor, to keep the estrogen levels down. And there's some really good data from a large group in Spain that's been doing a ton of this work that shows pretty comparable egg yields, even when using the letrozole. For BRCA, inheritance is autosomal dominant. There are over 15,000 different mutations known for BRCA1 and 12,000 for BRCA2. Some patients express a concern about passing their cancer on to offspring, and we do have the means of doing pre-implantation genetic diagnosis. Again, it adds an additional $10,000 to the treatment, but we can biopsy cells from the embryo, freeze the embryos, send them off for testing, and then transfer unaffected embryos to the patient. So I'm just going to close by mentioning that, patients have a lot of questions about safety, fear that they may pass their cancer on to an offspring. In reality, only 5 to 10% of cancers are hereditary. Patients are worried that their cancer may recur during pregnancy or cause detrimental maternal outcomes during a pregnancy, but we see that even with hormone-responsive malignancies, no adverse outcomes with regard to cancer recurrence or survival due to pregnancy have been noted in multiple studies. There's fear of adverse fetal effects, but we also know we have very good data that children are not at increased risk of genetic abnormalities, birth defects, or cancer themselves, aside from that small proportion that have a genetic predisposition. So in summary, options include medical protection of the gonads. It's promising but not perfect. We have options of ovarian tissue grafting. It's safe in most cancers, not leukemias. Ovarian function does come back in almost all patients after about 4 months, and pregnancy rates overall are approximately 30%, but the most standard and well-tested method is oocyte or embryo cryopreservation. So we know that women who store at least 7 eggs have approximately a 27% chance of live birth later. So that's, and 7 is an easily attainable number from one of these cycles. Usually we get even twice that. So thank you very much for your time and attention today. I just want to let you know my colleagues who are also available to do these consults over at UVM. And there's our direct nursing line for patients to call with questions. Easier than going through the front desk, I think. But any questions at this time?
What's the effect of nursing? If you're able to have a pregnancy that comes to term, with breast cancer, are these women able to adequately produce?
Often not, because if they've had a mastectomy, that even with the reconstructive surgeries, they can't.
Or what about if they've had radiation and the breast is still present?
It can significantly impair lactation afterwards. And then for other cancers, if there's been effects on the, on the neuroendocrine axis, that can affect prolactin levels and lactation afterwards. Great question. Anything else? Thank you.